Thank you, Brad. Good morning, everyone. We all danced out. My name's Ardell Otten, and thank you for joining me today. I'd like to spend a little time telling you about the challenges of rural healthcare. I'm going to use a client who lives in a rural environment and tell a little bit about the demographics and the challenges of rural healthcare environments in particular. I think that's kind of a fuzzy photo of a ferry, which looks like it might be whisking people off to some really beautiful vacation spots. Some of that may be true, but for the most part, it is workers arriving to and from work every day by boat because of the remoteness of the area. My client was a 41-year-old man of Portuguese descent. English is his second language. He presented to me with a partial traumatic transphalangeal amputation. He had injured the tip of his index finger repairing his lawnmower. He went to the emergency department where he received treatment of wound sterilization, x-rays, sutures, and a fingertip plaster. He was referred to a surgeon, a hand surgeon, who re-examined and treated the wound. We're going to call the client Senior Omen, which means Mr. Man. And I always call my clients Mr. or Ms., whatever their preference is, until they ask me to stop doing that. When he came to see me, when Senior Omen came to see me, he was very upset because he was calling the wound specialist, the surgeon, because he was afraid that his finger was becoming infected. And he was worried that he might have to have it amputated. And the surgeon was not returning his call. I'll return to Senior Omen a little bit later, but I would like to speak about the demographics and challenges of the rural communities, like Senior Omen's. Finally, I'll just share with you some of the tips that I've come to use to become the best advocate that I can for my community and myself. So rural communities are defined by the USDA as open countryside with population densities less than 500 people per square mile. The U.S. Census Bureau has basically the same definition. Senior Omen's community has a population density of 180 people per square mile. Really, really rural. According to the GAO, about 60 million of the population American population live in rural counties. That's about 18% of the population. And to give you a comparative perspective, Mississippi and Virginia have 50% of the population in rural areas. Maine and Vermont, 60% of their population live in rural areas. Texas, North Carolina, Pennsylvania, and Ohio have the largest rural populations. Massachusetts has about 8% rural. Oh, I neglected to tell you early on that in Senior Omen's community, he is 7 miles from the closest land other than his small island community. That 7 miles is Cape Cod, which is also a very rural community, and the largest urban area is Boston, which is about 90 miles away. So access to Senior Omen's community is limited to boats, ferries, airplanes. Most rural populations across the country face similar challenges, particularly with respect to health care. The 2020 census reports that the poverty rate in the rural U.S. is about 14%, and that compares to 12% nationwide. And depending on the state, unique challenges exist in all of the urban communities. For example, the General Accounting Office says that pregnant women, Black, Indigenous people of color, and veterans in rural communities face even greater challenges. There are not only fewer hospitals, there are fewer providers, and limited access to broadband. Okay, So these rural communities have fewer access because no broadband, inadequate coverage, low number of providers living and working in those communities, particularly in farming communities. According to the USDA, 15% of all rural counties are persistently poor, compared to 4% of urban counties. According to the Economic Research Service, the average per capita income for all Americans in 2020 was about $60,000. The average rural per capita income is around $46,000. In Senior Omens community, the per capita is $43,000, less than the rest. The American Community Survey found that 17% of the rural population is 65 or older, compared to 14% in urban areas. If the rural community is a seasonal resort where people go for vacations during the winter or the summer, their health care becomes exacerbated because they face other challenges like food insecurity and housing insecurity. According to the CDC, rural communities have higher rates of substance use, such as cigarettes and opioids, higher rates of chronic health problems, including obesity and high blood pressure, and greater exposure to environmental hazards like pesticides. All of these are true in Senior Omens community. So the U.S. federal, I guess I'm supposed to advance the slide at some point. No, I'm still good. The federal government defines rural health care systems. In the United States, I think there might be about 10,000 various designations of rural health. There's a rural health clinic, there's a federally qualified health center, there are short-term hospitals, and there are critical access hospitals. Most of these are in rural areas, but in some cases they're in large urban areas where access might be limited because of social, economic demographics. The main advantage of a rural health designation is that these facilities receive some preferential reimbursement rates from Medicare and Medicaid. And they also get some modified support depending on their designation with malpractice insurance. Little is known by patients nor appreciated by patients that in their community, if they have a rural designation, 50% of their clients, 50% of the caregivers, the providers, need to be non-physician providers. They need to be nurse practitioners, PAs, certified nurse midwives, and so on. Remember that ferry, bringing people to and from work? Well, shortages among physicians, nurses, and ancillary personnel is really intense. Many of the clients in those communities use emergency rooms as a substitute for primary care. And that shortage of providers leave many residents without primary care. I just met someone yesterday who said she lives in a rural area and she uses the urgent care center as her primary care. So in areas where urgent care centers exist, they seem to be cropping up more and more. It's a good thing. Most current data I found was in 2018 when there were 500 people on waiting lists in Senior Omens community waiting for a primary care doctor. Post-COVID, that number has gone up. English as the second language populations really are affected seriously by limited access. According to scholars from the University of Massachusetts Medical School, there could be up to 6,000 Brazilians living in Senior Omens community at any time. So what do we do to help minimize these challenges? While I've tried to offer some comparisons to rural communities across the country, particularly related to the access and socioeconomics, I'd like to just tell you some of the strategies that have worked for us. One, I guess I should advance this. Understanding the strengths and limitations of the system providing the care. As advocates, our role is to manage expectations when there are limitations, both for our clients and for ourselves. Sometimes the community simply cannot provide the services like adequate skilled nursing beds, medical specialists. It took Senior Oman a week to see a hand surgeon. Our solution for him was, after talking to the surgeon who was not returning his calls, we actually got him to, and the surgeon was very apologetic, offered him an appointment on Cape Cod, 7 miles away across the ocean. But by that time, the client had lost confidence in that physician. So he went to Boston. We arranged for him to see a hand specialist in Boston. And fortunately, his hand was healing and he had no infection. But all of that took about 15 days in order for him to get that. Understand where your safety net partners are. If patients are having difficulty with accessing health care, they also sometimes have different with food insecurity. And so you need to know where are their food pantries, where are their housing shelters, to help alleviate some of those issues. Also, we need to know where the closest urban hubs are and know what resources those hubs can provide to the patients in their communities. And oftentimes, local clinics or libraries can help set up telehealth sessions for community members. One of the most important things I'd like to say is be prepared to gently educate providers across the care spectrum, because a major hurdle is that many times providers don't understand the role of an advocate. So it's really critical when you're working with a client and a provider to introduce yourself and ask them if they've worked with an advocate before. If not, help them understand your non-intrusive role. Oh, I'm over time, but if anyone has questions at the end, I have lots more to say. So thank you.
Good morning. I'm Terry, and I can tell you all about who I am in my career later because I want to take my full 10 minutes to talk about my case. And I'm talking about a case in the city setting, and we all have the advantage of trying to figure out how to operate the clicker, right? So my case is the city case. My client was a 41-year-old client. And I actually have permission to use his name because he signed and did a video testimony for me. So his name is Mr. Trice. At the time, he was 40, and he initially got sick in June of last year with a cholecystectomy, ended up with an ERCP ×2 in June of 2022. He was re-hospitalized in August with complications from the initial surgery. Those complications included a pancreatitis that resulted in obtaining a pancreatic pseudocyst fistulizing to the descending colon. A lot of mouthy phrases, and I can answer those later if you don't know what they are. We can Google them, right? That created a large fluid collecting around the right, and I'm not going to say this word right, iliopsoas muscle. There you go. Thank you. He ended up coding twice prior to becoming my client, or while becoming my client, had SVT, and then ended up finally with a diagnosis of necrotizing pancreatitis. If you don't know, 30% of people die. Only 70% live with necrotizing pancreatitis. And if they do live, they have ongoing, long-term, complicated, and repeated necrotizing pancreatitis. And so the treatment was over 9 weeks in the acute care setting in the hospital, in a hospital in Plano, Texas, right outside of the Dallas Metroplex. And over that 9 weeks, he had NG tube, he had TPN feedings. He was on and off the vent every time they had to go in and do a necrotic washing out of the gut. He would end up back on the vent. It would take 24 to 48 hours to remove him off of that vent. He had incredible pain management issues. I mean, pain like I've never seen with a patient. We also were managing splenic artery bleeds as well as splenic stenosis. We were not sure if he would end up with a pancreatic removal, a splenic removal, if he would end up a diabetic. Those things we were not sure of during this 9 weeks of taking care of him. How did I get this client? I was at home on a Sunday night, relaxing after church. It was probably 6:30, 7:30. I get a phone call from a panicked wife. My husband's being medevaced from Denton, which is considered rural in Texas. Those of you that are from rural areas would not consider Denton rural, but for us, it's rural. And they were medevacing him to Plano. He was coding while they were medevacing him. They communicated nothing to the wife except, we're medevacing your husband. She was 3.5 hours away in Oklahoma. This family lived in Frisco, another city in the Metroplex, and had just moved to Oklahoma to homestead. She homeschooled 2 kids under 10, and she also fights a chronic illness of MS. So she called me, and after getting turned down by 2 advocates who would not take her case because they don't take hospital cases if they haven't had them as a client before, she said, would you please take my case? 45 minutes later, she was onboarded. The next morning, I was in the hospital. So what are some of the strategies? Some of the things that I encountered with this patient, thankfully at 40, which is unusual, they had a medical power of attorney, financial power of attorney, advance directives, and a living will. That has not been my experience with 85-year-olds. Thank God they had this. Some of the other strategies were managing the treatment plan of necrotizing pancreatitis. We have one surgeon in the Metroplex who is the guru on necrotizing pancreatitis. Guess what? He goes to all 50 hospitals within a 2-hour radius. So to get on his list and to be operated on weekly, you might be MPO all night and all day and have your procedure canceled. Imagine how that made the wife and him feel. Coordination of care of multiple physicians. We had the hospitalist, we had pain management, we had critical care, we had the ICU doctors, we had all of his outstanding doctors. And so trying to coordinate all that care was also another strategy that I had to figure out. Communicating with the insurance company. Because they have decisions on how long a patient can stay in the hospital, how long a patient can stay in the ICU. And then also discharge planning, because we all know we start discharge planning when you're admitted, even though you're dying. We're going to still plan that discharge. And then education of the client, the family, and the patient on what that's going to look like. And this story is a huge story, and I would love to tell it in greater detail. But to share the stage with us 3 fabulous women, I'm shortening that so I can tell you more details. But here's some of the biggest kind of takeaways that I had. This patient was on a fentanyl drip, dilaudid every hour. And the hospital said to me, you cannot speak on his behalf even though you have a release of information, because the medical power of attorney, the wife, really doesn't get to be the medical power of attorney because he's not incapacitated. I'm sorry, as nurses and doctors, if you're on a fentanyl drip and IV dilaudid every hour, what do we know? You can't drive and you can't sign consent for surgery, but you cannot have your wife give permission to an independent patient advocate. So I had to convene the ethics committee and the hospital advocate to fight for me to even help the family whose wife is 3.5 hours away. So I won that battle. It was persistent. I literally stood for 2.5 hours on the floor, watching the case manager, watching the manager, watching the hospital advocate, not knowing that they didn't know that I was there watching them. They thought, oh, if I make her wait long enough, she'll leave. Yeah, no, I won't. I'm persistent. So the other thing that happened is trying to get that coordination of the medical team, which I was able to do. The one thing that was really, really sad is about halfway through the 9 weeks, insurance says we need to move to a lower floor. So ICU, 2-to-1 ratio. Now we're going to go to 5-to-1 daytime, 6, 7, 8-to-1 at night. Mind you, every time he had a necrotic washing, he ended up back on the vent. So we fought. The wife was like, there's no way this can happen. We advocated, we fought. The wife called the ICU doctor, and the ICU doctor wrote an order. Absolutely cannot move this patient. Less than 22 hours later, he coded for the 3rd time. Over 33 units of blood. The doctor said I stopped counting at 33. I made the hardest phone call of my life and said, get a sitter, come to the hospital. I don't know if your husband's going to make it. So I get to the hospital. He's back in the ICU. I'm not kidding you. When I walked into his room, it looked like a murder scene. There was blood all over the couch, blood all over the recliner, blood all over the poles. There was 4 units of blood on ice on the floor and a crash cart. This is how sick this man was. I go out to the manager and I said, can I please gown up and clean this room? The wife is on her way. I mean, could you imagine walking into that? I mean, I walked into that and was like, oh my gosh, like, I don't know that I've ever taken care of somebody so sick. So I was able to clean that up. One of the other most amazing things is people, when I say people, staff don't listen. This patient was trying to write in my hand. So I got a paper and a pen and he wrote hot. He wanted the warming blanket off of him. So I went to the nurse and they said, there's no way he's talking to you. And I'm like, do not tell me, look at this paper. He is talking to me even though he's on a vent and even though he's highly sedated. He had a strong will to live. He had 2 kids and a wife, right? He was the main breadwinner in this family. So we were able to get in there and to take off that warming blanket. And then discharge services is the other big takeaway that I have, because I had helped coordinate the discharge planning. Because he was going 3.5 hours home, I wanted meds delivered to the room before leaving. I wanted to be there. The wife was like, oh, you don't need to be there. I wanted the discharge to be on a Thursday, not on a Friday. It happened on a Friday. So I met her there. And I called to the pharmacy in Oklahoma. Did you get the order? Yes, we got the order. They called back. Guess what? We're not going to prescribe these meds because you need to prove to us why he needs this much pain medicine. I said, no, you don't understand. This is a reduction in pain medicine. So even with the pain management doctor calling, the pharmacy would not fill it because the insurance denied it. So this family paid $9,000 out of pocket for pain management meds. They got a bill from the medevac, $70,000, and said, you didn't get pre-auth because you were dying, and so we're not going to pay. But page 26 of their health insurance plan said unless it's a high-risk sustaining life emergency. So we were able to appeal and fight, and we got the medevac paid for. We got the pain medicines paid for. And I can tell you 11 months later, this man is at home with his 2 children, with his wife, and doing wonderfully. This family did a 45-minute video testimony. If you go to my website, there's a link for that, and you can listen. I was able to ask questions and ask them, how you felt about an advocate. How do you feel about what happened to you? It's an incredible story. And just because you live in a city and you have access to everything doesn't mean care is easy. Thanks. And next is Deidre.
Good morning, everyone. Can everyone hear me? Well, I'm so happy to be here. Thank you to Health Advocate. This has been awesome. It's been awesome. Thank you. Thank you. So I'm going to talk about a transition of chronic illness. My specialty is chronic illness. I've been a nurse for 25 years. Background is massive. So I was approached. I'm going to start at the bottom here. Right. Okay, so I was approached by a trustee in West Virginia. His client was in Dallas, Texas. He said that his client needed help with transitioning of care. He lived in a home with an 82-year-old caregiver. He was 62 years old when I met him. He had ended up having a motor vehicle accident 20 years ago. So he's about 42, 43 in that area. And he ended up with a traumatic brain injury. His sisters lived out of state. So one lives in Cape Cod and the other one lives in West Virginia as well. So basically what they wanted me to do was be able to coordinate care because he has a traumatic brain injury. He can't remember things. He really needs to be educated over and over again, almost like you have Alzheimer's. You got to just kind of repeat it, short-term memory loss. So I was to accompany him to doctor's visits and also make sure that the sisters understood what was going on with their brother, because the main thing is gaps in communication. That's what I'm finding. People want to know about their loved one. They want to be updated consistently on their loved one. So this little gentleman, when I met him and I met the caregiver, I was like, the caregiver needs more help than he does. She had more comorbidities, so it was just like, whoa, what are we going to do? So basically, their plan and their goal was to age in place. So if you want to age in place, there are many, many resources that we find as patient advocates, because I network a lot. And getting up my resource pool and then just helping the family know what's next, 6 months, 9 months down the line. Now, I knew when I met this caregiver at 82, she never went to the doctor because she was so concerned about caring for him. He was unable to walk. He was wheelchair bound. He was a solid 220 pounds. So what ended up happening, by the grace of God, we did a crisis intervention plan. And what I formulate as a crisis intervention plan is like planning for the what if. What if he falls? What if she falls? What are we going to do? His sisters are out of state. His trustee is out of state. He has no family here. She doesn't drive much because she's short of breath. So basically, it was like, what are we going to do to get everybody to calm down in the event of a crisis? Because unfortunately, ICU nurse, I always kind of plan for the back, right? So if he falls or if she falls, so we got the family on a Zoom call and we all formulated a plan. Who's going to do what if he or his caregiver falls? Who's going to call 911? Who's going to contact the doctors? Who's going to contact the family members? Who's going to contact what resources do we have? Do we have an assisted living locator? If she falls, he cannot take care of himself alone in that home. He doesn't walk. He was able to pivot and, bear weight to get from the wheelchair, but just wait for it. So we did this crisis intervention plan and everybody was all copacetic. Then he ended up having an emergency appendectomy. This gentleman, because of his motor vehicle accident, his pain receptors somehow below the belt, he doesn't feel pain. So anybody who is having appendicitis, you're in excruciating pain. He was just kind of tired, nauseated, vomiting. So when he started vomiting, we said, go to the ER. So, of course, we have to call 911. He gets to the ER. They do surgery. But during surgery, he ended up developing a blood clot in his lower right leg. Planned on discharge planning, like Terry so eloquently put. It starts at admission. You hit that door, they treat you and they street you. They don't care about what happens when you get outside that door. Sorry, I said it. Yep. So basically, they were saying that he needed to go to a SNF because insurance did not approve rehab because he couldn't tolerate the 3-hour time limit. So he goes to they give him a list. So I physically, because I don't care what you say, that Medicare.gov list, they put those stars on there. You better go see that facility. So I physically go out and I look for a facility and I keep the family members updated. This is the facility. This is what this one has from a nursing perspective. How's the staff? I'm looking at the staff. I'm looking at the culture. I'm looking at everything. So they ended up picking a pretty good facility. He goes there. He stays there for about, I would say 3 weeks, insurance approved, and the plan is to go back home. But when the facility saw the caregiver, they were like, are you sure? That's what they wanted. That's the goal. We can bring resources into the home. So I ended up getting them a standalone, why is this not going forward? Okay. I ended up getting them a standalone home health company to come in, working with the home health nurse, because I need to know when you go in there, I need to be there at that assessment. I need to be there for the future planning. I need to be there when someone comes into the home. Well, he fell again. So the caregiver, bless her heart, she was like, are you sure that he needs to go to ER? He's on blood thinners. Anybody who's on a blood thinner, I don't care if you hit your head or not, you're going to the ER. So this time, while he was in the ER, she fell and ended up going into the hospital. So now we got to have a whole plan revamped. So we went back to our crisis intervention plan. Nobody panicked. All the caregivers and the lovely sisters were like, okay, I've called the attorney. I've called this. I've done that. I called the facility where he went back to. This time he's asked to stay in there for long-term care because there's no way he could have gone back home and she could have cared for him adequately. So in all this process, it was about decreasing the communication gaps, making sure they knew exactly what was going on when it was going on, being able to put it on their level so they understood that the healthcare providers that we had brought in were doing the best they could. Now, the big thing was the facility that he went to didn't understand what an independent patient advocate was, didn't understand how an independent patient advocate could help collaborate with them. In addition, so the social worker ended up saying to me, really snooty, oh, Deidre, well, he has a social worker. And I said, lucky for him, he has an independent nurse advocate as well. So our goal was to basically help empower and help the other caregivers coordinate care. We are not there to step on your toes. We are not there. We can keep you out of court. That's what we can do. So patient advocacy means our team joins your journey. And when I say your journey, I mean the entire journey. When I'm at doctor's visits with my clients, I make sure that they understand what the other side is saying. They understand how to incorporate individualized care planning, not putting you in the box because you have CHF, not putting you in your box because you have ALS, being a real caregiver and provider. That's where it's at. My name is Deidre Kindred. I'm an independent patient advocate, navigator, and educator, and we're going to change the world.